primary horizontal chop in a post-vitrectomy, post-LASIK eye with surprise small pupil management and zonular loss issues. This is my favorite case from this week. Let's get into it. Because of the post-LASIK status, I calculated the lens power for this patient using the Barrett True K formula, making my biplanar main incision and initiating the capsular rhexis. At this point, the pupil looks okay. I could do a phaco through that. But as I proceed in the capsular rhexis, I notice that the pupil is getting smaller. I have learned the hard way that it is never too late to put the ring. Even though the capsular rhexis is already initiated, I am now planning to put the ring in. I finish off a capsule rhexis, making sure it's not too tiny. Now going in with viscoelastic and putting a dollop of viscoelastic in the sulcus nasally, inferiorly, and superiorly. This is the order that the rings will come out. So hooking it nasally, then tilting it a little bit inferiorly so I can hook the inferior one, and then tilting it superiorly so I can hook the superior one. And then just going in with the ring manipulator and hooking the temporal one. Now I am decompressing the AC and starting my hydrodissection. I also like to do hydrodelineation in almost all of my cases for that additional capsule protection. Now going in with the phaco probe and aspirating all the loose fluffy cortex and epinucleus. Now I've slowed the video down to its normal speed to show the step. Going underneath the anterior capsule edge horizontally and then turning the chopper to make it vertical. Now lifting the back up from the chopper to make it such that it wraps around the endonucleus. Positioning the phaco probe subincisionally, going in on the chop setting and going up to 50 to 60% depth of the endonucleus. Now bringing the chopper to the phaco probe while holding the vacuum and separating the two. That's the primary horizontal chop, just separating the two heminuclei and spinning the endonucleus to make a chop in the heminucleus so I can create quadrants. Repeating the same maneuver, except this time I don't have to go into the chop setting and burrow my way into the heminucleus. I can just go in the pre-existing groove. Now pulling out the quadrant that I made and turning it some more to remove the second quadrant. I like to sub-chop these quadrants as well. The primary horizontal chop technique varies slightly depending on the grade of the nucleus. For very soft lenses, I must remember that I don't have to use phaco energy. I can just use vacuum to hold the nucleus in place while my chopper does the work. For really hard nucleuses, like 4 plus NS brunescent ones, I have to make sure that I use enough phaco energy to get to an adequate depth. Otherwise, my chop will end up being superficial and I will leave a plate behind. I can crack that plate by switching to a stop and chop, but if I am careful about how deep I go with my phaco probe, I do not encounter that problem. Now I have eaten up all the endonucleus and some of the epinucleus, switching to the IA handpiece and eating up the remaining epinuclear shell. Also starting to pull the cortex because this epinuclear shell is kind of sticky. That's the last bit of the epinucleus. This is a post-vitrectomy eye, so I expected the bag to billow a little bit, but watch what happens. As I'm removing the subincisional cortex, the bag comes to the center from the superonasal. I've slowed it down for you to watch again. Watch the superonasal part. There's the bag. At this point, I decide that there has been some zonular loss in this quadrant and I decide to put a CTR in. Going in the bag with some viscoelastic and centering the ring. I am going to use a large CTR. You can size a CTR using the white to white, but I just defaulted to a large CTR in this case to keep things simple. Now loading up the CTR and hooking the one end with a Sinski so I can release it gently into the capsular bag. and injecting it. Another trick I learned was to keep it as tangential as possible while injecting it, and now releasing it using the Sinski from the injector. That's it. The CTR is in. Now inserting the IOL in the bag, and I must remove the ring now. My preferred technique of removing the ring is actually using the injector. I first unhook the most distal hook and then just rotate the rest of the hooks out and use the injector to grab on to the proximal hook, retracting the ring back into the injector until I reach the middle two hooks and then pulling it out with the injector itself. I feel like this is the least traumatic way of removing the Malyugin ring, and this is my preferred technique. Now removing the viscoelastic with IA probe and hydrating my incisions. Patient did really well, 20/30 on post-op day 1 with a normal pressure. Let me know if you have any recommendations on if I should do things differently, and thank you for watching.